Welcome to Chapter 12 of the Glaucoma series. In this section, we'll focus on the medical management of glaucoma and ocular hypertension. We'll explore how pharmacologic therapies are used to lower intraocular pressure, how different medication classes work, and how to tailor treatment for individual patients. By the end of this chapter, you should have a solid understanding of the principles behind each drug category, their mechanisms of action, and the clinical decision-making that guides their use. When managing glaucoma medically, everything begins with defining a target pressure. This is the intraocular pressure threshold that the clinician estimates will prevent further functional vision loss. Determining that target isn't arbitrary. It takes into account the patient's baseline pressure, optic nerve status, rate of progression, and other individual risk factors. There are 5 main classes of topical medications used to lower intraocular pressure, and these are often combined for greater efficacy. Selecting the right medication requires balancing potency with contraindications, side effect profile, and cost, all while keeping the patient's adherence in mind. Among these, prostaglandin analogues are the mainstay of first-line therapy. They lower pressure primarily by increasing uveoscleral outflow and are favored for their once-daily dosing and strong IOP lowering effect. Before diving deeper into the specific medications, it's important to step back and define the ultimate goal of glaucoma therapy. Our main objective is to preserve visual function, and we do that by lowering intraocular pressure. But successful treatment isn't just about numbers. It's about achieving pressure reduction with the least possible risk, the fewest adverse effects, and minimal interference in a patient's daily life. Cost is another crucial factor in this equation, especially for chronic therapy that may span decades. Long-term success is judged not simply by pressure readings, but by the stability of the visual field, the optic nerve, and other structural markers. Ultimately, adequate and sustained IOP reduction remains the cornerstone measure of how effective our management truly is. Now that we've defined the overall goals of glaucoma therapy, let's look more closely at the concept of target pressure. Target pressure represents the intraocular pressure below which further symptomatic vision loss is unlikely during a patient's lifetime. Establishing this threshold early on promotes a thoughtful, risk-based approach and helps individualize management from the start. Determining the right target pressure requires considering factors such as baseline IOP, extent of optic nerve damage, rate of progression, age, life expectancy, and comorbidities. But setting a target once isn't enough. At every visit, clinicians must reassess, ensuring both structural and functional stability. Even if the target pressure is achieved, ongoing monitoring is critical to confirm that the disease truly remains controlled. Once we understand what target pressure represents, the next step is to individualize it for each patient, and in fact, for each eye. The target pressure should reflect the intraocular pressure level at which damage is believed to have occurred, and the degree of that damage. This means the same patient might have 2 different targets between their eyes. Adjustments to the target depend on several factors: the observed rate of progression, if it's known, the patient's life expectancy, and their overall risk profile. Prior disc hemorrhages, thin corneas, and a strong family history of severe glaucomatous vision loss all push us towards setting a lower target. In practice, establishing an individualized target pressure is about balancing protection of vision with realistic, sustainable treatment, a theme that ties back to the broader principles discussed earlier and will carry through the rest of this chapter. The severity of disease at presentation plays a major role in determining how low the target pressure should be. Patients with more advanced optic nerve damage require lower pressure targets to minimize the risk of further vision loss. When there's already significant visual field compromise, even small additional losses of ganglion cells can have a much greater functional impact on the patient's daily life. Setting that target IOP is part of what many call the art of glaucoma management. There isn't one universal formula. Different clinicians may approach it differently, and there's no clear consensus backed by large-scale trials, since glaucoma progresses too slowly for such studies to be practical. Reaching the target often takes time and usually requires more than one adjustment, whether that's adding or changing medications, improving adherence, or escalating to procedural therapy. It's a dynamic process, not a fixed number. Progression can still occur even when intraocular pressure is measured below the set target. In those cases, a lower revised target may be needed. This underscores that glaucoma control is not purely numerical. It's clinical and individualized. Once a target is set, it serves as a guideline, not an absolute mandate. Every additional intervention, whether medical, laser, or surgical, must be weighed carefully against its risks and expected benefit. Overtreatment carries its own consequences, especially when the potential visual gain is small. Table 12-1 in this chapter provides a general framework for estimating target intraocular pressure, but there's no universally accepted system. Ultimately, clinical judgment remains central, and this is where the physician's experience and the patient's unique context truly shape care. When setting an initial target pressure, we rely on general ranges like those summarized in Table 12-1. These provide a framework rather than strict cutoffs, but they're helpful starting points for clinical decision-making. For patients with ocular hypertension, meaning normal optic discs and visual fields, treatment, if initiated, usually aims for a pressure under 25 millimeters of mercury or about 20% below baseline. In cases of mild glaucomatous damage, where there's disc change but a normal visual field, the target is typically below 21 millimeters of mercury and about 25% lower than baseline. As damage becomes moderate, with visual field loss in one hemifield outside the central 10 degrees, the target drops further, generally under 18 millimeters of mercury and around 30% below baseline. For severe glaucoma, where both hemifields or the central 10 degrees are involved, the recommended pressure goal is often under 15 millimeters of mercury, again about 30% below the patient's baseline. These values serve as a clinical guide, but the patient's individual risk profile, tolerance, and disease behavior ultimately determine the ideal pressure goal. After establishing an initial target, it's equally important to recognize the factors that might shift that goal up or down for a given patient. Certain features signal the need for a lower target pressure. These include a history of optic disc hemorrhage, a thin central cornea, or evidence of rapid disease progression, especially if the fellow eye has already suffered severe vision loss. A strong family history of blindness from glaucoma or onset of damage at a young age are also red flags that call for a more aggressive target. Conversely, there are situations where a higher target pressure may be acceptable. Patients with limited life expectancy, significant systemic comorbidities, or a history of stable, slowly progressive disease might not benefit from the risks associated with further IOP lowering. Similarly, a thicker cornea can lead to overestimation of true pressure, which sometimes justifies a slightly higher goal. In practice, these adjustments reflect the nuance of glaucoma management, balancing protection of vision with realistic and individualized care. Once the target intraocular pressure is defined, the next question becomes how to reach it. Clinicians must weigh whether to pursue medical, laser, or surgical therapy, and that decision always comes down to balancing benefit against risk. Every intervention must justify its potential side effects. Medications or procedures with significant adverse effects should be reserved for patients whose risk of progression truly warrants them. Conversely, if more aggressive therapy introduces substantial risk or discomfort, maintaining a slightly higher than target pressure may be reasonable, especially in lower risk or older patients. Ultimately, glaucoma management is a constant balance, weighing the risk of treatment against the threat of disease progression and its effect on the patient's quality of life. Once the target pressure has been set and the risks and benefits considered, the next step is selecting the appropriate initial therapy. For most cases of ocular hypertension and open-angle glaucoma, first-line treatment typically begins with either topical medications or laser trabeculoplasty. Topical agents remain the most widely used starting point, largely because they're effective, accessible, and reversible. However, selective laser trabeculoplasty has gained traction as an alternative or adjunct, particularly for patients who struggle with medication adherence or have contraindications to drops. Some clinicians may attempt a unilateral treatment trial, treating one eye and comparing the response to the untreated eye, but this approach has limitations. Intraocular pressure can fluctuate asymmetrically between eyes, so differences may not accurately reflect medication efficacy. From here, we'll move into a closer look at the specific classes of topical medications and how each works to lower intraocular pressure. There are several main classes of ocular hypotensive agents used to lower intraocular pressure. These include prostaglandin analogues, adrenergic drugs, carbonic anhydrase inhibitors, parasympathomimetic or miotic agents, Rho kinase inhibitors, combination medications, and hyperosmotic agents. Each class works through a distinct mechanism, and we'll go through them one by one in the next few slides. Prostaglandin analogues are prodrugs that become active after being converted by corneal esterases once they penetrate the cornea. They lower intraocular pressure mainly by increasing uveoscleral outflow and reducing resistance through the outflow pathways. These agents act primarily on PGF2 alpha receptors, which stimulate matrix metalloproteinases. This activation leads to remodeling within the ciliary body, trabecular meshwork, and possibly the scleral extracellular matrix. The result is increased spacing between ciliary muscle fascicles, allowing fluid to exit the eye more easily through the uveoscleral route. The prostaglandin analogues include 5 commonly used agents: latanoprost, travoprost, bimatoprost, tofloprost, and latanoprostene bunode. As a class, they typically lower intraocular pressure by about 25 to 33%. Tofloprost tends to be slightly less effective than latanoprost, while latanoprostene bunode, a nitric oxide donating analog, has shown roughly a 1 mm of mercury advantage over latanoprost in clinical studies. These medications are dosed once daily, most often at night. Interestingly, twice-daily dosing is actually less effective due to receptor saturation. If the response after 4 to 6 weeks is inadequate, switching to another agent within the same class can sometimes improve results. Prostaglandin analogues have a few characteristic side effects, with one being particularly unique. They can cause permanent darkening of the iris and surrounding periorbital skin. This occurs due to an increase in melanosome density, not cell proliferation. The risk varies by baseline iris color, occurring in up to 79% of green-brown irises, 85% of hazel eyes, and about 8% of blue irises. Importantly, there's no evidence that this pigment change increases the risk of melanoma. Other side effects include conjunctival hyperemia, especially with bimatoprost and travoprost, as well as hypertrichosis, trichiasis, and sometimes dystichiasis. Most of these non-pigment changes are reversible once the medication is discontinued. Beyond the more common cosmetic and ocular surface changes, prostaglandin analogues can also cause structural changes around the eye, known as prostaglandin-associated periorbitopathy, PAP. This includes a deepened upper eyelid sulcus, upper eyelid ptosis, enophthalmos, and increased inferior scleral show, which can give the orbit a tighter appearance. These findings are thought to result from periorbital fat atrophy, and while some improvement has been reported after discontinuation, the degree of reversibility remains uncertain. Other significant risks include cystoid macular edema, particularly in aphakic or pseudophakic eyes with open posterior capsules and in eyes with underlying uveitis. Prostaglandins can also trigger reactivation of herpetic keratitis and, less commonly, cause a non-granulomatous anterior uveitis, which occurs in about 1% of patients. Beta-adrenergic antagonists lower intraocular pressure by inhibiting cyclic AMP production in the ciliary epithelium, which reduces aqueous humor secretion by roughly 20 to 50%. This results in an overall pressure reduction of about 20 to 30%. In healthy eyes, a compensatory decrease in outflow facility can blunt the full effect, but in glaucomatous eyes, the reduction is more pronounced. The onset of action is rapid, occurring within about an hour, and the pressure-lowering effect can persist for up to 4 weeks after discontinuation. Because of systemic absorption, these drops can occasionally lower pressure in the untreated contralateral eye. They also have minimal impact at night, since aqueous production naturally decreases during sleep, making them less effective for nocturnal pressure control. There are 5 topical beta blockers commonly used in the United States and Europe: betaxolol, cartiolol, levobunolol, metiprenol, and timolol. Betaxolol is the only beta-1 selective agent. It's often better tolerated in patients with pulmonary disease, but tends to be slightly less effective at lowering intraocular pressure. Most beta blockers are approved for twice-daily dosing, though many of the non-selective agents can be used once daily with similar results. Morning dosing is preferred to counter the early morning rise in intraocular pressure and to reduce the risk of nocturnal hypotension. Non-selective agents like timolol at 0.25% are often just as effective as the 0.5% concentration. About 10 to 20% of patients show little to no pressure-lowering response to topical beta blockers. Patients who are already taking oral or systemic beta blockers often gain minimal additional benefit from adding topical therapy. With long-term use, some patients may develop tachyphylaxis due to receptor upregulation, which can reduce the drug's effectiveness over time. Lowering intraocular pressure can also trigger physiologic changes within the trabecular meshwork, decreasing outflow facility and partially offsetting the benefit. If the underlying disease continues to reduce outflow capacity, intraocular pressure may eventually rise again, even while the patient remains on a beta blocker. Topical beta blockers can be absorbed systemically through the nasal passages, reaching plasma levels similar to oral therapy because they bypass first-pass metabolism. Using gel formulations or performing punctal occlusion can help reduce systemic absorption. Systemic side effects include bronchospasm, so these drugs should be avoided in patients with asthma or chronic obstructive pulmonary disease. They can also cause bradycardia, heart block, and systemic hypotension. Patients may experience reduced exercise tolerance, central nervous system depression, such as fatigue or mood changes, and occasionally depression. In diabetic patients, beta blockers can reduce glucose tolerance and mask the warning symptoms of hypoglycemia. Abrupt withdrawal may worsen symptoms of hyperthyroidism. Ocular side effects include corneal anesthesia, punctate keratitis, and allergic reactions. Before prescribing beta blockers, always ask about asthma, since blocking beta-2 receptors can cause life-threatening bronchospasm. The beta-1 selective option, betaxolol, is somewhat safer, but it's not completely risk-free. Check the patient's baseline pulse and avoid treatment if the heart rate is too low or if there's more than first-degree heart block. Beta blockers can also trigger symptoms of myasthenia gravis, even in patients who were previously undiagnosed. Other side effects can include lethargy, fainting, lightheadedness, visual disturbances, sexual dysfunction such as impotence or reduced libido, and lipid changes, including lower HDL cholesterol. These medications should also be used with caution in children because systemic exposure is higher in that age group. Okay, let's move on to non-selective adrenergic agonists. These include epinephrine and dipivefrin, which is a prodrug of epinephrine. These agents lower intraocular pressure by decreasing aqueous humor production, while simultaneously increasing both uveoscleral outflow and conventional outflow through the trabecular meshwork. They're rarely used today, having been replaced by newer and more selective drug classes. Frequent local side effects further limit their use, and they are no longer available in the United States. Now, let's talk about the alpha-2 selective adrenergic agonists. These agents lower intraocular pressure primarily by reducing aqueous humor production. The alpha-2 receptors on the ciliary epithelium activate an inhibitory G protein which decreases adenylate cyclase, lowers cyclic AMP, and ultimately decreases aqueous production. There's also an additional mechanism involving vasoconstriction of the anterior segment vessels, which reduces ciliary body blood flow and further limits aqueous humor formation. Brimonidine also increases uveoscleral outflow, likely through smooth muscle relaxation. This effect is not seen with apraclonidine. There may be a small systemic crossover effect, but it's generally minimal. There are two agents in the alpha-2 selective adrenergic agonist class. The first is brimonidine tartrate, which is the most widely used alpha-2 agonist. It tends to cause less tachyphylaxis compared to apraclonidine. Apraclonidine hydrochloride acts as both an alpha-2 agonist and a clonidine derivative. However, it isn't suitable for long-term therapy because of a high rate of tachyphylaxis and frequent hypersensitivity reactions, including blepharoconjunctivitis. It's mainly used in the perioperative setting to blunt acute intraocular pressure spikes following procedures such as laser iridotomy, laser trabeculoplasty, YAG capsulotomy, or cataract extraction. Brimonidine can also be used effectively in these same perioperative scenarios. Brimonidine reaches its peak intraocular pressure reduction of about 26%, roughly 2 hours after instillation. Its efficacy is comparable to that of non-selective beta blockers and slightly better than betoxolol. The trough reduction, about 12 hours after dosing, is around 14 to 15%, which is somewhat less than the non-selective beta blockers. There are a few key limitations. Brimonidine does not lower nocturnal intraocular pressure, and while tachyphylaxis can occur, it tends to be less prominent than with apraclonidine. In terms of dosing, it's FDA approved for use 3 times daily, though in practice it's more commonly used twice daily. It's often prescribed in combination therapy with at least one other agent. Allergic reactions such as follicular conjunctivitis or contact blepharodermatitis are possible. These are less common with brimonidine than with apraclonidine. The reaction is typically a delayed type hypersensitivity and dose-dependent. After 1 year, the incidence is around 15% with brimonidine, 0.2% preserved with BAK, and about 10% with the 0.15% purite preserved formulation. Allergy rates continue to rise beyond 1 year, though cross-sensitivity between apraclonidine and brimonidine remains minimal. There's a high long-term intolerance rate, over 20%, due to local adverse effects. Rarely, brimonidine has been associated with anterior uveitis. Finally, alpha-1-related ocular effects can occur from some alpha-1 receptor binding, including conjunctival vasoconstriction, pupillary dilation, and eyelid retraction. Apraclonidine has stronger alpha-1 affinity, making it more likely to cause mydriasis, whereas brimonidine tends to cause miosis. Now, let's go over their systemic adverse effects and some contraindications. Because of their clonidine-like central nervous system effects, these medications can cause xerostomia, or dry mouth, lethargy, and fatigue. More serious reactions include central nervous system depression, which can lead to apnea, bradycardia, and hypotension. In pediatrics, brimonidine must not be used in infants or young children since it can cause life-threatening central nervous system depression. Drug interactions are another concern. MAO inhibitors and tricyclic antidepressants can interfere with the metabolism of brimonidine, increasing the risk of toxicity. Finally, during patient counseling, it's important to advise punctal occlusion to help reduce systemic absorption and minimize these side effects. Next, let's shift our attention to carbonic anhydrase inhibitors, or CAIs. These medications reduce intraocular pressure by limiting the formation of aqueous humor. They block the enzyme carbonic anhydrase in the ciliary epithelium, which decreases bicarbonate production and fluid transport into the posterior chamber. Systemic CAIs extend this effect through renal metabolic acidosis, which dampens sodium-potassium ATPase activity in the ciliary body. Because carbonic anhydrase is present in many tissues, like the corneal endothelium, iris, retinal pigment epithelium, red blood cells, choroid plexus, and kidneys, the action isn't limited just to the eye. For a meaningful drop in intraocular pressure, over 90% inhibition of ciliary epithelial carbonic anhydrase is needed. The main topical agents are dorzolamide and brinzolamide. These are often used for long-term intraocular pressure control since they have fewer systemic side effects compared to oral CAIs. Both are FDA approved for 3 times daily dosing, but in practice, most clinicians use them twice daily with very good effect. Using them 3 times a day can provide a slightly stronger IOP reduction. Lastly, if a patient is already taking a full-dose oral CAI, adding a topical CAI does not provide any additional benefit. All right, now let's turn to systemic carbonic anhydrase inhibitors. These are typically reserved for acutely elevated intraocular pressure or as a short-term bridge before surgery. Oral agents begin working within about an hour, reaching maximal effect around 2 to 4 hours. Intravenous dosing acts faster, usually within 15 minutes. Sustained-release acetazolamide peaks between 3 and 6 hours. The 2 main systemic agents are acetazolamide and methazolamide. Acetazolamide is excreted by the kidneys, so dosing should be adjusted in renal insufficiency. Methazolamide lasts longer, has less protein binding, and is better tolerated, though slightly less effective. It's metabolized by the liver instead of the kidneys. For dosing, always aim for the lowest effective amount to reduce IOP adequately. Methazolamide is usually dosed 25 to 50 milligrams 2 to 3 times daily. Acetazolamide is typically given as 250 milligrams 4 times daily for the standard formulation or 500 milligrams twice daily for the sustained-release version. Let's wrap up our discussion of carbonic anhydrase inhibitors by reviewing their adverse effects, both topical and systemic. Starting with the topical forms, the most common complaint is a taste disturbance, often described as a bitter or metallic aftertaste. Patients may also experience blurred vision or a mild burning sensation after instillation. Dorzolamide tends to sting more due to its lower pH, while brinzolamide can leave white tear film deposits since it's a suspension. Long-term use can occasionally lead to punctate keratopathy, and in eyes with compromised endothelium, there's a risk of corneal decompensation. For the systemic agents, side effects are typically dose-related and stem from metabolic acidosis. Patients may notice paresthesias in their fingers or toes, fatigue, anorexia, or even weight loss. Other effects include gastrointestinal discomfort, psychiatric symptoms such as severe depression, and sexual dysfunction with reduced libido or impotence. Finally, systemic CAIs can also cause a taste disturbance, which is often worse when drinking carbonated beverages. Before wrapping up the carbonic anhydrase inhibitors, it's important to highlight their key contraindications and special risks. Patients with sickle cell disease are at increased risk of triggering a sickle cell crisis, so CAI should be used with extreme caution or avoided entirely. These agents also raise the risk of renal stones, particularly calcium oxalate or phosphate stones, although this complication is less common with methazolamide. In patients with hepatic cirrhosis, CAIs are contraindicated because they alkalinize the urine, which reduces ammonia excretion and can lead to hepatic encephalopathy. The same urinary alkalinization effect can further impair ammonia clearance even in patients without overt liver disease. Lastly, use caution in renal insufficiency, since acetazolamide is excreted unchanged by the kidneys and can accumulate to toxic levels if renal function is reduced. Continuing with the contraindications and special risks of carbonic anhydrase inhibitors, let's touch on a few important safety concerns. Because CAIs are sulfonamides, they can occasionally trigger allergic reactions in patients with sulfa allergies. However, true cross-reactivity with sulfonamide antibiotics is uncommon. Only about 10% of patients show a reaction. It's thought to reflect a general predisposition to allergic responses rather than a structural cross-sensitivity. That said, CAIs should still be avoided in anyone with a history of severe sulfonamide reactions, such as anaphylaxis or Stevens-Johnson syndrome. There are also rare but serious idiosyncratic effects, including aplastic anemia, other blood dyscrasias, Stevens-Johnson syndrome, and hepatic necrosis. Because these reactions are unpredictable, routine CBC monitoring isn't helpful or recommended. Lastly, CAIs can cause electrolyte imbalances, most notably hypokalemia, especially if used alongside potassium-wasting diuretics like thiazides. For patients on those combinations, it's best to monitor serum potassium to prevent complications. Now let's shift gears and move on to the parasympathetomimetic agents, also known as miotics. These medications have a long history in glaucoma management. They've been around for over a century. Miotics work by stimulating the parasympathetic system to constrict the pupil and improve aqueous outflow through the trabecular meshwork. There are two main categories. First, the direct-acting cholinergic agonists, such as pilocarpine, and second, the indirect-acting anticholinesterase agents, which enhance the effect of acetylcholine by preventing its breakdown. Now focusing on the direct-acting parasympathetomimetic agent pilocarpine. This medication is still used today, though typically in specific situations rather than as a long-term therapy. It's particularly helpful in pigmentary glaucoma, where it can blunt exercise-induced IOP spikes, in aphakic eyes with elevated intraocular pressure, and in cases of plateau iris where angles remain narrow or occludable despite a patent laser peripheral iridotomy. However, pilocarpine has several limitations. Adherence is often poor due to the need for 3 to 4 daily doses, and many patients struggle with its adverse effect profile. In certain cases, lower concentrations can still be used effectively for mild iridotrabecular contact after iridotomy. As for the indirect-acting agents, these are rarely used today because of both ocular and systemic side effects. They may retain some value in aphakic glaucoma, but overall, their use is limited in modern practice. Let's take a closer look at how parasympathetomimetic agents actually work. These medications function by contracting the longitudinal fibers of the ciliary muscle, which pull on the scleral spur and the trabecular meshwork. This action widens Schlemm's canal and improves outflow facility, allowing aqueous humor to drain more efficiently and lowering intraocular pressure. Direct-acting agents, like pilocarpine, bind to muscarinic receptors and mimic the action of acetylcholine at parasympathetic junctions. In contrast, indirect-acting agents inhibit acetylcholinesterase, which breaks down acetylcholine, so they effectively prolong endogenous acetylcholine activity. Overall, pilocarpine can typically lower intraocular pressure by around 15 to 25%. Now, let's go over the adverse effects of parasympathetomimetic agents. Starting with ocular effects, these drugs can induce myopia from ciliary muscle spasm, often accompanied by brow ache. Patients may also experience worsened vision in dim light due to miosis, especially if lens opacities are present. There's a known association with retinal detachment, so a careful peripheral retinal exam should be done before starting therapy. Long-term use has been linked to cataract formation, particularly with indirect-acting agents. Other ocular findings include iris cysts, tearing, punctal stenosis, and even drug-induced pseudopemphigoid on the ocular surface. From a surgical and inflammatory standpoint, miotics can increase bleeding risk during surgery and enhance post-operative inflammation, including fibrinous uveitis. They're generally avoided in uveitis because they can disrupt the blood-aqueous barrier. Regarding angle and lens effects, there's a potential for paradoxical angle closure, especially in phacomorphic eyes with large lenses, due to forward displacement of the lens-iris diaphragm, which can worsen pupillary block. Finally, systemic effects, primarily from indirect-acting agents, include diarrhea, abdominal cramps, salivation, bronchospasm, and urinary incontinence. Importantly, succinylcholine should be avoided for up to 6 weeks after discontinuing these agents because of prolonged neuromuscular blockade. Let's shift focus to the Rho kinase inhibitors, a newer class in glaucoma pharmacotherapy. The Rho family of G proteins plays a central role in regulating cell structure, controlling stiffness, shape, adhesion, and smooth muscle tone. Their main effectors are the Rho kinases, specifically ROCK1 and ROCK2. When activated, these kinases phosphorylate downstream proteins, including myosin light chain phosphatase, which leads to increased myosin light chain phosphorylation. The result is tighter actin-myosin interaction, increased cell stiffness, and enhanced smooth muscle contraction. By inhibiting Rho kinase, these drugs essentially relax the trabecular meshwork and Schlemm's canal, reducing resistance to aqueous outflow. The physiologic outcome is an increase in conventional outflow facility, directly targeting the primary drainage pathway for aqueous humor. Now, let's look at the available Rho kinase inhibitors and how they're used clinically. The first agent developed was ripasudil, introduced in Japan as a ROCK1/ROCK2 inhibitor. It was followed by nitarsudil, which gained FDA approval in 2017. Nitarsudil is unique. It acts as both a ROCK1/ROCK2 inhibitor and a norepinephrine transporter, NET inhibitor, which can further lower episclerovenous pressure and possibly reduce aqueous production. In terms of efficacy, Rho kinase inhibitors typically achieve IOP reductions comparable to or slightly less than timolol. For patients with baseline IOP around 22 millimeters of mercury, nitarsudil's 0.02% once daily produces roughly a 20% decrease. When combined with latanoprost, the effect increases by another 1.3 to 2.5 millimeters on average. Interestingly, some patients exhibit stronger individual responses than expected from mean trial data. As for dosing, nitarsudil is given once daily, with nighttime administration preferred because conjunctival hyperemia, its most common side effect, is usually most prominent in the first few hours after instillation. Let's finish by reviewing the adverse effects of ROCK kinase inhibitors. The most frequent issue is conjunctival hyperemia, occurring in roughly 50 to 60% of patients. This redness results from vascular smooth muscle relaxation in the conjunctiva and tends to be most intense during the first few hours after instillation. Subconjunctival hemorrhages occur in 15 to 20% of users, generally mild and self-limited. Other ocular complaints, seen in about 5 to 10%, include itching, punctate keratitis, tearing, blepharitis, and transient blurred vision. A distinctive finding is cornea verticillata, reported in 15 to 25% of patients after a year of therapy. These are whorl-like epithelial deposits, similar to those seen with amiodarone. Importantly, they have no impact on visual acuity and typically resolve within a year after discontinuation, thought to result from lysosomal phospholipid accumulation. Lastly, reticular corneal edema has been described, though its true incidence is still uncertain. Overall, while these side effects are usually mild and reversible, their frequency makes patient counseling, especially regarding redness, essential before starting therapy. Let's wrap up with combined glaucoma medications, which simplify multi-drug regimens and improve adherence. The main advantage of combination drops is convenience. A single bottle can replace 2 separate agents, improving compliance and reducing preservative exposure. They're especially helpful when a patient already needs multiple medications to reach target IOP. Common combinations include timolol plus CAI, marketed as COSOPT; timolol plus alpha-2 agonist, usually brimonidine, known as Combigan; timolol plus prostaglandin analog, latanoprost, travoprost, or bimatoprost; brimonidine plus brinzolamide, branded Simbrinza; and more recently, latanoprost plus natarcedo, marketed as Rocklatan. Note that Repressa is natarcedil alone. In terms of efficacy, these combinations generally produce similar IOP lowering to using each component separately. However, with timolol-containing combos, the total beta-blocker exposure can be higher than needed, and many patients still achieve good control with once-daily dosing. From a safety perspective, the adverse effects mirror those of the individual agents. Before starting a fixed combination, clinicians should ensure that each component provides measurable IOP benefit when used alone. That way, the combination truly adds value rather than unnecessary exposure. Now, let's shift to hyperosmotic agents, which are reserved for acutely and severely elevated intraocular pressure. These medications, most notably oral glycerol and IV mannitol, work by raising plasma osmolality, creating an osmotic gradient that pulls fluid out of the vitreous and thereby lowers IOP. The effect is dose and rate dependent, meaning higher or faster administration leads to greater pressure reduction. Among them, mannitol is particularly effective because it stays within the extracellular compartment and enters the eye more readily when the blood-aqueous barrier is disrupted. However, their effect is temporary, lasting only a few hours. As plasma and intraocular osmolarities equilibrate, efficacy wanes, and if the agent later diffuses back into the eye, a rebound IOP rise can occur. These drugs also lose potency in conditions where the blood-aqueous barrier is already compromised, such as uveitis. Adverse effects include headache, confusion, and fluid overload, which can precipitate heart failure or myocardial infarction, especially with IV use. Rarely, subdural or subarachnoid hemorrhage has been reported. For glycerol, a key caution is its potential to trigger hyperglycemia or ketoacidosis in diabetic patients. When thinking about long-term glaucoma management, the key is that therapy must be individualized. Each patient requires a specific target IOP based on their baseline pressure, optic nerve status, and rate of progression. The goal isn't just to lower pressure, it's to preserve vision and quality of life over decades. Importantly, IOP alone is not enough to judge treatment success. We must evaluate both structural and functional change through serial assessments. Careful optic nerve exams, RNFL imaging, and visual field testing over time. This longitudinal follow-up allows clinicians to distinguish stable disease from progression, even when IOP appears well controlled. When choosing a medication, 4 main factors come into play. Efficacy, since some classes provide greater average IOP reduction than others. adverse effect profile, balancing potency with tolerability, cost, which influences long-term adherence, and finally, the likelihood the patient will actually use the drops as prescribed, since adherence often determines outcomes more than drug selection itself. In essence, glaucoma treatment is a marathon, not a sprint, requiring individualized goals, structured monitoring, and a realistic approach to patient behavior. When initiating glaucoma therapy, the general rule is to start with a single topical medication unless the intraocular pressure is dangerously high and requires immediate multi-drug intervention. This stage should always involve shared decision-making with the patient, discussing potential side effects, cost, dosing frequency, and expected adherence. The first-line agents are typically the prostaglandin analogues, thanks to their high efficacy, once-daily dosing, and favorable safety profile. They provide the greatest average IOP reduction with minimal systemic risk. Beta blockers remain an effective alternative, but they have more systemic effects and do not lower nocturnal IOP, making them less ideal for certain patients, especially those with pulmonary or cardiac comorbidities. If prostaglandins or beta blockers cannot be used, several reasonable alternatives exist. Notarsidil, a Rho kinase inhibitor that enhances trabecular outflow. Brimonidine, an alpha-2 agonist that both reduces aqueous production and increases uveoscleral outflow. Or a topical carbonic anhydrase inhibitor, which reduces aqueous humor secretion. Ultimately, the goal is to tailor therapy to each patient's physiology, comorbidities, and lifestyle, starting simple and building only as needed. If the initial drop isn't controlling pressure adequately, the next step depends on the response pattern. If there's minimal effect, it's reasonable to switch to a different class. But if there's partial benefit, the more efficient option is to add a second medication with a complementary mechanism. At any point in this escalation process, laser trabeculoplasty can be considered, either as an adjunct or even as an initial therapy, especially for patients struggling with adherence or systemic contraindications to drops. For patients already on a prostaglandin analog, the typical add-on choices include a beta blocker, an alpha-2 agonist, a topical carbonic anhydrase inhibitor, or a Rho kinase inhibitor. These agents all provide roughly similar additive IOP reduction when used in combination, though CAIs may offer slightly better nocturnal pressure control. Ultimately, the decision should weigh efficacy, side effect profile, dose inconvenience, systemic contraindications, and patient preference. The art of glaucoma care lies in balancing those elements while minimizing treatment fatigue. When multiple glaucoma medications are needed, the regimen should be customized to the individual patient's needs and tolerance. For example, parasympathomimetics can still play a limited role in aphakic eyes, where other agents may be less effective. Once patients require 3 or more drops, adherence tends to fall, and both ocular and systemic side effects become more frequent. At this point, consider simplifying the regimen with fixed combination drops. They make adherence easier but don't reduce the rate of side effects, since the same active agents are still being used. A common and often overlooked issue is BAK toxicity, especially in those on chronic multi-drop therapy. BAK acts as a preservative, but can cause ocular surface irritation, dryness, and inflammation. When this becomes problematic, it's best to switch to preservative-free or alternatively preserved formulations, such as those using purite, Savzia, or borate-based systems. The table on the right shows the difference preservative-free and alternatively preserved ocular hypotensive agents. Ultimately, managing multiple agents is about striking a balance, maximizing efficacy while minimizing burden on both the ocular surface and the patient's daily routine. When patients develop side effects from glaucoma medications, the first step is often temporarily stopping all topical agents, as long as their optic nerve damage allows for a short pause. This helps determine whether the symptoms truly stem from the drops or another cause. During this break, encourage preservative-free artificial tears to support the ocular surface. And if pressure control is needed, consider a short-term course of oral carbonic anhydrase inhibitors. One of the biggest challenges is recognizing systemic side effects. Patients rarely connect fatigue, shortness of breath, or mood changes with their eye drops. That's why ophthalmologists need to actively ask about systemic symptoms and review potential drug-drug or drug-disease interactions. For instance, combining topical beta blockers with oral antihypertensives or asthma medications. Finally, coordination with primary care is key. Discuss the potential systemic impacts of glaucoma medications and how other treatments might influence IOP. A good example is the interplay between oral beta blocker therapy for hypertension and topical beta blockers. Adjusting one can unintentionally affect the other's efficacy or safety. When intraocular pressure spikes acutely, the primary goal is to prevent irreversible optic nerve damage. Alongside that, treatment should aim to clear corneal edema to restore visualization of intraocular structures and reduce intraocular inflammation. To achieve this quickly, we rely on hyperosmotic agents, either oral glycerol or intravenous mannitol, to create an osmotic gradient that draws fluid out of the vitreous, rapidly lowering pressure. In cases of severely elevated IOP, systemic carbonic anhydrase inhibitors can be added to further suppress aqueous production. Speed is crucial. When IOP is extremely high, ischemia of the iris sphincter can develop, rendering pilocarpine ineffective. Lowering the pressure first helps restore pupillary constriction, which is essential before performing a laser iridotomy in acute angle closure. If left unchecked, very high IOP can even collapse Schlemm's canal and collector channels, shutting down conventional outflow entirely. Prompt reduction in pressure not only prevents optic nerve compromise, but may also reopen these outflow pathways, restoring normal aqueous drainage once the crisis has passed. Proper administration of ocular medications is crucial for maximizing drug effect while minimizing systemic absorption. Patients should be taught correct instillation technique, including nasolacrimal occlusion, pressing the inner canthus for 1 to 3 minutes after drop instillation to reduce systemic absorption and extend ocular contact time. They should also be instructed to gently close their eyes, but not squeezing, after applying drops to improve corneal penetration and limit systemic uptake. This step is particularly important when using beta blockers, alpha-2 agonists, and topical carbonic anhydrase inhibitors, which have higher potential for systemic or taste-related side effects. When using multiple drops, they must be spaced at least 5 minutes apart to avoid washout and ensure each drug is absorbed effectively. Providing written or visual medication schedules helps reinforce this routine. Finally, for patients who have difficulty self-instilling, such as older adults or those living alone, dosing aid devices can improve adherence and precision, ensuring therapy is both effective and sustainable. During pregnancy, IOP often decreases naturally, but many glaucoma patients still need active management. The challenge lies in balancing disease control with fetal and maternal safety, since most topical glaucoma medications undergo systemic absorption and can cross both the placenta and into breast milk. When definitive safety data are limited, treatment decisions should be made collaboratively between the ophthalmologist and obstetrician. Ideally, glaucoma management plans should be discussed before conception, allowing time to adjust medications or consider laser and surgical alternatives. When topical agents are necessary, emphasize nasolacrimal occlusion to minimize systemic absorption, and always use the lowest effective dose possible. Medication minimization is key, reducing both the number of agents and their frequency when safe to do so. If medical therapy poses significant risk or is poorly tolerated, laser trabeculoplasty or other surgical approaches may be preferred when the benefits outweigh potential risks. Importantly, anti-fibrotic agents such as mitomycin C and 5-FU should be avoided due to known evidence of human fetal harm. Prostaglandin analogues require special consideration during pregnancy due to their pharmacologic similarity to naturally occurring PGF2 alpha, which can affect uterine tone. These medications were previously classified as pregnancy category C, indicating animal data suggesting risk but no adequate human studies. In animal models, PGF2 alpha analogues have shown embryocidal effects in rodents at doses many times higher than those used clinically, 15 to 97 times the human ocular dose. Similarly, travoprost was teratogenic in rats at intravenous exposures reaching up to 250 times the maximum human ocular dose. At pharmacologic extremes, prostaglandins can increase uterine contractility, raising theoretical concerns about inducing labor if systemic exposure were significant. However, at typical ophthalmic doses, systemic absorption is minimal, and topical PGAs are unlikely to pose significant fetal risk. That said, given the absence of robust human data, clinicians should proceed with caution, especially in early pregnancy, and weigh the necessity of treatment against potential, albeit low, systemic exposure risks. Beta blockers, though effective for lowering intraocular pressure, raise several concerns during pregnancy and lactation. These agents were previously listed as pregnancy category C, indicating potential fetal risk based on animal studies or clinical observations. Both systemic and topical beta blocker exposure have been linked to fetal or neonatal growth retardation, arrhythmias, bradycardia, and lethargy, highlighting their ability to cross the placenta. Because they are concentrated in breast milk, topical beta blockers like timolol are relatively contraindicated during breastfeeding due to the risk of neonatal bradycardia or hypotension. When used, therapy should be approached with caution, employing nasolacrimal occlusion to reduce systemic absorption and using the lowest effective dose. Whenever possible, alternative agents should be considered, especially in late pregnancy or while nursing, to avoid potential cardiovascular or developmental effects in the infant. Let's go over the pregnancy considerations for alpha-2 agonists. These medications were previously categorized as pregnancy category B, meaning they showed no harm in animal studies but lack strong human data. Brimonidine is generally the preferred option during pregnancy based on the safety information we do have. However, it has been associated with apnea in infants, so it should be stopped before delivery to avoid neonatal complications. It should also be avoided during breastfeeding because of the risk of central nervous system depression and potential apnea in infants. Additional pediatric considerations are discussed in the dedicated pediatric chapter. Let's review the pregnancy considerations for carbonic anhydrase inhibitors. These medications were previously labeled as pregnancy category C. Animal studies have shown teratogenic effects in rodents, and there are case reports describing forelimb deformities in infants exposed to systemic forms of these drugs. Because of this, systemic carbonic anhydrase inhibitors should be avoided in pregnant women. It's also best to avoid topical carbonic anhydrase inhibitors when possible, especially during the first trimester. Let's shift from pregnancy to elderly patient considerations. When treating elderly patients, it's important to recognize the unique challenges they face with glaucoma medications. Many have trouble instilling drops because of tremor, poor coordination, or arthritis, and that alone can compromise adherence. Cognitive decline or complex dosing schedules can make adherence even more difficult, especially in the setting of polypharmacy. They are also more vulnerable to systemic side effects from topical glaucoma medications. Both beta blockers and alpha-2 agonists tend to produce a higher rate and greater severity of systemic reactions in this population. A meaningful number of elderly patients can even experience reversible reductions in pulmonary function when using beta blockers. Let's shift to the role of generic medications in glaucoma care. A large portion of commonly used agents are now produced in generic form, and these products are required to be chemically and biologically equivalent to their branded counterparts. That said, the formulation itself isn't always identical. Differences in preservatives, bottle design, or vehicle can meaningfully change how the drug performs for certain patients. Bromonidine and bimatoprost are classic examples. Various generics on the market may differ slightly in active concentration or tolerability. Even with those nuances in mind, the lower cost of generics is a major advantage. Improved affordability almost always translates into better adherence, which is a key determinant of long-term glaucoma control. Let's wrap up by looking at the factors that really drive adherence. Patients stay on their regimen far more reliably when they have a clear grasp of what their disease is, what the treatment is trying to achieve, and what side effects they should expect. That understanding needs to include the alternatives as well. People make better decisions when they know their options. Another major driver is simplicity. The fewer medications and the lower the dosing frequency, the more likely patients are to stick with the plan. Tying drop installation to predictable daily routines, meals, brushing teeth, bedtime, also reinforces consistency. A written schedule can be surprisingly powerful, especially when multiple agents are involved. And none of this works unless installation technique is correct, so confirmation in clinic is essential to make sure those drops are actually getting where they need to go. All right, last slide. We're looking at the sustained-release bimatoprost implant. This is the intracameral biodegradable device approved in 2020 for single-use application. Each implant delivers 10 micrograms of bimatoprost embedded in a PLGA matrix that gradually degrades within the eye. The Phase 3 program followed patients for 20 months and used 3 sequential implants placed 16 weeks apart. In terms of efficacy, both the 10 and 15 microgram doses produced IOP lowering on par with twice-daily Timolol. Neither dose fell short. What stands out is durability. About 69% of patients in the 10 microgram arm didn't need any additional therapy through month 20. The major limitation is safety. Corneal endothelial cell density loss was the signal that ultimately constrained wider use. By month 20, greater than 20% CECD loss occurred in roughly 10% of the 10 microgram group and nearly 22% of the 15 microgram group. That's the key risk that reshaped enthusiasm for repeated implantation. That wraps up our review of glaucoma medical therapy and special considerations. Thank you for your attention, and we'll see you in the final lecture of the glaucoma series.